Hi everyone, this is Neel Raithatha, consultant audiologist and director of earwax. Thank you for joining me in my latest video using the iClearScope endoscope, and I have a couple of procedures for you. They both involve the right ear of a couple of patients, and the reason why I've paired them together is because both patients have really narrow ear canals which can pose challenges when removing earwax. So patient one, this wax is quite soft, sticky, so I've just put some medical grade olive oil spray in there just to change the consistency. So it helps to coagulate this soft wax and skin, and it just makes it easier to suction away. So the more lateral aspect of this patient's earwax was quite straightforward, but there was a plug a bit deeper in the ear. It wasn't fully occluding. You'll see it in a moment, which is a bit more challenging to remove because of the narrow and also bendy ear canal. And they did mention that they had earwax removed before, but there was a bit that they weren't, the specialist that they saw before wasn't able to remove, but it wasn't causing them a problem, and that's fine. When you remove earwax, if there's a little bit of wax left and it's difficult to remove and it's not causing the patient any symptoms, then it's sometimes best to leave well alone. By removing it, you can possibly cause trauma, injury, and for no added benefit. So the specialist that they saw previously did the correct thing, and I can understand the challenges. It was quite tricky. So the Zollner suction probe that I'm using at the moment, it's got an outer diameter of 2.1 millimeters and undilated. So when I mean undilated, so there's points in this procedure where I'm retracting the patient's pinna. So the pinna is the auricle, the satellite dish made up of cartilage on each side of our head. So by pulling that back and up, you're actually stretching straight in the ear canal, but undilated in a normal resting state, the normal Zollner suction probe will just about enter the ear canal in this region here, the isthmus, in between the first and second bends. I'm using the fine end at the moment. So the fine end, this is an 18 gauge, so it's got an outer diameter of about 1.26, 1.28 millimeter. So because it's narrow, it's a bit easier to insert. So you can see this wax a bit deeper in the ear. It's in the inferior recess, and I'm using the endoscope now to stretch open this patient's ear. So this is a procedure where possibly the wax scope might be a bit more beneficial because you've got the speculum to stretch and straighten the ear canal. And again, the consistency of this wax is such that it's difficult to remove. I did try to put some more oil in, but because of the architecture of this patient's ear canal, as it's bendy and twisted, it's very difficult for it to penetrate deep in the ear. So I think I had to go just there, but not much oil has seeped downwards towards this patient's eardrum. So I'm just going to go back in. And the important bit here is not to embed the suction tip too much into the soft wax, because you're just going to block the tip of the suction tube. So you just want to hover over the surface and gently release. I think it did get blocked a couple of times for me, so there's one example. As you can see, I put the oil in, but it just kind of sat at the entrance. It just wasn't flowing through, and you can see again there I'm just suctioning some of the excess oil because it can sometimes blur the screen. Guys, just wanted to say thank you all for whoever's subscribed to my other YouTube channel, So Neel Reads. I'll put the link in the description. But a few weeks ago, I had many requests. I've been having many requests for a while, truth be told, to read books, poems, etc. and upload it, because people, for some reason, found my voice to be very soothing and relaxing. So I started a new YouTube channel. I've got, I think, just over 700 subscribers in the last few weeks. So thank you guys. It's great to know that there's people actually subscribing to this YouTube channel and enjoy listening to me read. And I did it partly for myself as well, because I'm just so engrossed into work in recent years. It's good just to have a release, and just by reading books, poems, I enjoy that. I've not had the opportunity. I used to read quite a lot many years ago, but not so much recently. So it kind of gives me an excuse as well to read and improve my reading skills. So yeah, feel free to subscribe if that's something that is of interest to you. And also I just want to thank Nurse Richard, also known as the Wax Wizard. Richard reached out a while back. He brought some instruments, but I wanted him to try the full repertoire. So I kind of contacted him and says, look, you purchased these instruments. There was a straight ear hook and correct, but I really wanted him to try the angled one, so I just sent some samples to him for him to try, and he uploaded a video yesterday. It's completely unbiased. I wasn't involved in that. Whenever I provide samples, so recently with the wax scope for Connor, I provided Connor some sample instruments. I've also sent some sample instruments to both Reese and Tyler as well. I never kind of ask when they do a video or testimonial, like say this, say that. I just leave it up to the specialist, and I respect their views whichever way. But yeah, Richard left a really nice, some nice comments in his video yesterday. So I just want to say thank you to Richard. I'll leave the video URL for his review in the description section as well. So if you want to watch that, feel free to subscribe to Richard's channel. So this is patient 2. Now this patient's ear is a lot more narrower, and there was this added difficulty with all these hairs. Now I've had a few specialists contact me about the hairs, whether it's with an endoscope or they're using their head loops or microscope, about the hairs, and they just wanted some advice. So I gave some advice. So with an endoscope, you can actually, once you get through the hairs, then, because the hairs are normally located on the outer third, so you can see once you get past that barrier, the hairs don't become so much of an issue. But when the wax is quite lateral near the entrance, it can. So with an endoscope, the tip is really just kind of trying to pass through the hairs if you can. Now, I've got so used to the hairs now, so I can work with them, but yeah, they can. I can appreciate they can be challenging at times. So if someone's using a speculum, you can use a smaller speculum to go a bit deeper into the ear, or when you're inserting the speculum, you kind of rotate it, so you're kind of pushing the hairs aside. I did also purchase some blunt nose, rounded, curved kind of ear and hair kind of trimmers, but I didn't find them to be very good. So I've just found a decent kind of a nose and hair trimmer, and I kind of know how to disinfect it as well. So it's one of these you can wash and then we can disinfect, so we can use in between patients, because that's really important. We want to make sure it's decontaminated. And I'm going to give it a whirl, and it's a very slim line. It's an electric one, so it's going to be far more effective than the manual one. So I'll kind of use them with a few patients, and then I'll feed back to a fellow colleague specialist, and if there's something that they're interested in, I can give them the link for the trimmer that I've purchased. So let's see what we can do. Let's see if we can improve that kind of issue for some specialists, because I can appreciate it can be a bit of an issue at times, especially when if you put oil in. So I've put oil in this patient's ear, and you can see that even if you dry it, the oil coats these hairs, and the endoscope has to go through the hairs to enter the ear, so it can sometimes blur it. So I mean, the easy way around that is just coming back out and wiping the lens and just re-entering. But let's see. The only thing I was concerned about is some of these hairs flying out and about, but I think with this trimmer here, it kind of almost will just cut it at the root, and it hopefully it's got this kind of flared end, so it kind of almost will keep it within the bowl of the outer ear, so the cavum concha region, so instead of flying around. So hopefully it will kind of keep it there, and I can just suction them up. And it won't be a problem. So again, you can see just how bendy and narrow this ear canal is. There's a lot of dead skin here as well. So yeah, these kind of procedures, they're not the prettiest of procedures. They're not one of those big wide ear canals. Now, one of the things that we do train our specialists is, because I can appreciate if you've got a bendy, twisty ear canal and you're new to endoscopic earwax removal, it can be quite tricky to dilate the ear because there's no speculum. So you can, we do show our specialist how to ask the patient themselves, if possible, to dilate the ear and stretch it open for them, just to make it a lot wider. I typically don't do that. I prefer dilating the ear canal myself using the endoscope. But initially, when specialists are learning, it is one of the tricks. But of course, not all patients can stretch the ear open, because you're having to get the patient to do it with the opposite hand. So for example, if this is the patient's right ear, if you want the patient to dilate their ear open, you're going to have to get them to use their left hand and go behind their head and just pinch the the helix, which is the outer rim of the pinna, the auricle, so the satellite dish, and then pull it back and up. So some patients can struggle to do that. If they've got a loved one, or friend, family member attending, they can help. Some specialists may have assistance as well. So it's just something to kind of, there is kind of ways around that as well. So by dilating the ears, it's easier to enter and the hairs will become a bit less of an issue. But you can see there's so many hairs there. But apart from the view, I think for you guys, which you may not fully enjoy because of the hairs, hasn't really caused me a problem. So the eardrum's visible. There is an indentation, a bit more medially at the floor of the ear canal. There's no need to be concerned really, because there's no keratin building up there. Whenever you've got a divot or pothole like that, you've got to be wary that maybe a dead skin cyst can form, and that can lead to a canal cholesteatoma. But there's no sign of that. The skin is intact, so there's no ulceration. I mean, I did have a case yesterday of canal cholesteatoma. It's a patient I saw a few weeks ago, and I was umming and ahhing whether it was, and so they needed some medication, and I just invited them back for a review, and I do feel it's a canal cholesteatoma, so we have early stage, so we have referred to ENT. There's that little pothole at the bottom right, so they have got quite a bumpy floor of the ear canal. Well, I hope you enjoyed that video, guys. Take care, keep well, and speak soon. Bye.